Welcome back, students, to the Masterclass. So, in Part 95, we completely wrapped up our Advanced Medical DRG deep dive into MDC-10, covering all those endocrine, nutritional, and metabolic diseases. Well, today, for Part 96, we are flipping the script. We're moving over to the surgical side to decode the advanced surgical DRGs for MDC-10. We'll be unpacking everything from complex bariatric procedures to intricate endocrine and metabolic surgeries. Let's get right into it.
If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.
All right, we have a fantastic syllabus today. We're going to start by breaking down the MDC-10 surgical hierarchy. Then we'll hit the high-volume bariatric and endocrine DRGs, tackle amputations and debridement, and finally, we'll build our shield with PCS precision and audit defense.
Okay, jumping right into our first topic, the overarching surgical and metabolic hierarchy for MDC-10. Let's look at exactly how these cases partition out.
Now you might be wondering, what exactly triggers a case to become surgical in the eyes of the DRG system? Think of surgical partitioning like a trump card. When an inpatient undergoes an ICD-10 PCS procedure that's officially designated as an operating room procedure, that code essentially overrides the underlying medical principle diagnosis. Boom. Just like that, the case is pulled straight out of the medical partition and funneled into a surgical DRG selection within MDC-10.
So, what's actually living inside this surgical partition? The clinical scope here is pretty vast, but it's highly specific. We are primarily looking at bariatric and obesity operations and targeted endocrine gland resections, so your thyroid, parathyroid, adrenal, and pituitary procedures. But it also catches the really severe metabolic complications, like diabetic limb salvage amputations and complex soft tissue excisional debridements.
And CMS doesn't just guess how to categorize these, they use a very strict surgical hierarchy. Let's say a patient has multiple qualifying OR procedures. Well, the system actually sequences them from highest to lowest clinical complexity to lock in that final DRG. It prioritizes adrenal and pituitary procedures at the very top, then it moves down to bariatric surgery, followed by lower limb amputation, then thyroid and parathyroid procedures all the way down to skin grafting and debridement. It's a very rigid top-down approach.
Moving into Section 2, we are going to look closely at those high-volume surgical, endocrine, and metabolic DRG families. These are the ones you'll see every single day.
Let's start with the heavy hitters, MS-DRGs 619 through 621. These capture major operating room procedures for obesity. We're talking about the laparoscopic sleeve gastrectomy, the classic Roux and Yaw gastric bypass, and the incredibly complex biliopancreatic diversion with duodenal switch. And don't forget, this family also includes revisional bariatric surgeries for patients who, maybe need anatomical modifications years after their initial weight loss procedure. But here's the catch. You can't just code a bypass and call it a day. Securing these bariatric DRGs demands absolute precision in your principal diagnosis coding. The documentation literally has to establish qualifying morbid obesity. Typically, that means a body mass index of 40 or greater. Or if the BMI is 35 or greater, it has to be combined with major clinically severe comorbidities, things like severe type 2 diabetes or obstructive sleep apnea. If you miss that, you risk the entire DRG.
All right, let's move down the neck and down the hierarchy. MS-DRG 625 through 627 cover your thyroid, parathyroid, and thyroglossal procedures. The crucial differentiator here is whether the surgeon performed a total or a subtotal resection. For parathyroids, you have to know, was it a single gland, a subtotal resection, or a total removal with autotransplantation? Oh, and thyroglossal duct cyst excisions, those group directly into this family as well.
Now, I want to give you a golden rule for coding these neck surgeries. You always need to hunt for two specific operative details. First, always capture intraoperative nerve monitoring. Surgeons use this constantly to protect the recurrent laryngeal nerve. Second, you've got to clearly identify any concurrent central neck lymph node dissection. Grabbing these additional procedures paints the true clinical picture of the complexity and heavily impacts your facility metrics. Going right back to the top of our surgical hierarchy, we have MS-DRGs 614 and 615 for adrenal and pituitary procedures. These are incredibly resource-intensive cases. We're looking at laparoscopic and open adrenalectomies to treat serious conditions like pheochromocytoma, Cushing's adenoma, or Conn syndrome. This is also where you'll find your transsphenoidal resections for pituitary tumors.
That brings us to Section 3, amputation and debridement for endocrine disorders.
This is really where we see the intense management of severe metabolic complications.
For MSDRGs 616 through 618, we're categorizing lower limb amputations that are specifically driven by severe endocrine complications, usually things like diabetic gangrene or really stubborn refractory osteomyelitis. And precision is literally everything here. Your procedural coding must pinpoint the exact anatomical level. Was it a localized toe or transmetatarsal amputation, or did it escalate to a major below-knee or above-knee amputation? The code has to match the reality perfectly.
Just below amputations in that hierarchy, we find MSDRGs 622 through 624. These capture skin grafts and wound debridement. We see these interventions all the time for treating severe diabetic foot ulcerations and terrifying necrotizing wounds. But remember, to get here, it requires clear documentation of excisional debridement, meaning the surgeon actually cut deep down into the subcutaneous tissue, the fascia, or the muscle. Finally, Section 4. ICD-10 Precision, CDI, and Audit Defense. It's time to build your shield, protect your revenue, and ensure absolute compliance.
You've got to know exactly where you are in the ICD-10 PCS tables. Navigating this requires surgical precision on your part. For endocrine operations, you are headed straight to Body System 0G. But for bariatric procedures, you're routing over to Body System 0D for the gastrointestinal system. Selecting the right anatomical region and the exact approach, like was it open, percutaneous, endoscopic, via natural opening, that is absolutely fundamental to getting the correct DRG.
And root operation selection, that's where you have to act like a clinical detective. A total thyroidectomy or adrenalectomy, that is a resection. But if they only removed a piece, it's an excision. In the bariatric world, it's fascinating. A Roux-en-Y gastric bypass utilizes the root operation bypass, obviously, but a sleeve gastrectomy, that uses restriction because the whole objective of the surgery is to artificially limit the stomach's capacity. Make sure you don't mix those up.
Let's talk about severity drivers, because postoperative secondary diagnoses are massive here. Capturing a condition like postoperative hypocalcemia or tetany right after a thyroidectomy, or recognizing an adrenal crisis or a catastrophic bariatric anastomotic leak, these completely alter the clinical profile of the stay. Documenting any associated acute kidney injury or septic shock is absolutely crucial. It ensures your final DRG accurately reflects the massive resources it took to save that patient.
So I leave you with this provocative thought. Are your surgical records truly bulletproof against an audit? Commercial payers are incredibly aggressive right now. They will target bariatric surgeries for medical necessity denials all day long. They will comb through your operative reports just to verify the exact instrument and the exact depth used during an excisional debridement, or to question why a specific level of amputation was chosen. You have to be proactive and make sure the documentation is ironclad.
And that, my friends, wraps up our deep dive into the surgical side of MDC-10. You should now have a really solid grasp on the surgical grouping logic, the root operation precision you need for bariatric and endocrine surgery, and those strict rules surrounding diabetic complications. Now catch your breath, because next time in Part 97, we're kicking off a brand new Advanced Medical DRG deep dive, and this time we're tackling Major Diagnostic Category 11, Kidney and Urinary Tract. You won't want to miss it.
If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep learning, keep coding accurately, and I will see you in the next masterclass.